So we're going to start. Welcome to the Luncheon presentation. It's entitled Opiate Crisis and the Role of Hispanic Healthcare. We have two speakers, but three people will talk. The three of us will give you a talk. And I'm going to go ahead and present ourselves. We have Dr. Carlos Blanco. Dr. Carlos Blanco is a known expert in the epidemiology and treatment of addictive disorders. His accomplishments include a detailed examination of the course and stages of substance use disorders and the development to qualify generalization of clinical trials, and also to test the interventions that combine motivational interview with cognition, behavioral therapy, to improve the retention and outcome of individuals with addictive disorders. Prior to joining National Institute of Drug Abuse, Dr. Blanco was a professor of psychiatry at the Columbia University Medical Center and a research psychiatrist at the New York State Psychiatric Institute. He's a graduate of La Universidad Autónoma de Madrid and completed his psychiatry residency at Columbia University. He has authored about 300 peer-reviewed papers, and he's currently the medical director of the Division of Epidemiology Service at the Prevention Research of the National Institute of Abuse. It's great to have you here.
Well, thank you, Maria, for such a kind introduction, and thanks to all of you for coming to this session. So as you can see from this slide, the opioid crisis is probably the most important healthcare issue that we have in this country right now. From the number of deaths and the increase in the number of deaths, I cannot think of any other problem that can compare to the opioid crisis. And as you can see also in the map, if you look at the blue and go from 1999 to 2016, you can see that there's been an increase in overdose deaths across all countries, across all counties. So this is not the problem of the north or the south or the east or the west. It's not a problem of rural America or urban America. This is a problem that really affects all Americans, and so as such, we all have to take part in the solution. One thing that is often overlooked or people are not fully aware is that we don't have just one crisis. We really have a number of crises, at least three crises that overlap. And so as you can see there, the beginning of the crisis was more focused on prescription opioids. Then we had heroin, and then more recently we have fentanyl. As you can see, fentanyl is really taking over as the main driver of deaths. Of course, some of these the crisis overlaps. So some individuals use prescription opioids, others heroin, fentanyl, some of them use all of them. So we have overlapping crises. But I also want to call your attention to the heterogeneity and the variety of patients and people that you will see in your practices. So not everybody fits the same pattern. And that's something that until recently was not fully appreciated. Surprisingly, very little has been done to look at ethnic differences or how the crisis affect different ethnic groups. I was talking before the presentation to Pierluigi Mancini, and I was very happy to hear that finally the ATTCs are going to start collecting information for Hispanics and on hopefully for other ethnic groups to see both the characteristics of each ethnic group, but also what are the best practices that we can apply. Right now, we really don't know. As you can see in this slide though, Hispanics tend to have lower prevalence and lower incidence of overdoses, so the rate is lower at the same time, and so this is the total overdoses. If you look by heroin, or later on I will show you for fentanyl, the negative side though is that there's a steady increase, and if you look actually at fentanyl and other synthetics, the slope is getting steeper. So even though we are, as a group, have lower rates of overdoses, the future doesn't look that bright because it's getting worse. So unless we take very active action, things are not going to go very well. I also wanted to put in your mind the crisis in context. So we tend to think of the crisis as starting very recently, but as you can see in this paper that was published recently in Science, what you can see is that there's been an increase in overdoses over the last 40 years. Initially it was heroin, then it turned to cocaine, more recently heroin and other opioids. But one thing to take into account or to keep in mind is that the crisis is not something that has occurred abruptly, but this is something that has prepared over time, and unless we change the underlying determinants of this crisis, and we all take action, most likely the crisis is going to continue. And as you can see, as I showed also in the previous slide, not only it's continuing, it's really getting steeper. I mean, this is really an exponential growth curve. When we think about the crisis, we often think also only in terms of overdoses, but I also wanted to call your attention to the number of issues in which the crisis is affecting. So we have the overdoses, but we also have infections, HCV, hepatitis C, and HIV. I think hepatitis C is particularly important for two reasons. One is the high rates of infectivity, and the other is the dilemma that it poses in terms of allocating resources. So as you know, treating hepatitis C can be very effective, but it's very expensive. So it poses the question of, do we want to treat it? Because if you treat it, it's very, very expensive. But if you don't treat it, it's probably more expensive because there's going to be a high rate of contagion, and then you're going to have more cases. It also poses, from my point of view, a sort of an ethical dilemma and an issue of a stigma that I think does not apply to other diseases. So obviously many of the individuals who contract hepatitis C, it's because of risky practices, including substance use. And so we tend to think, well, in a way, they look for it, they deserve it. We don't think that way. If an athlete had multiple fractures, or if somebody had hypertension and didn't follow the diet, I don't think that most of us would think in those terms. But unfortunately, because of a stigma, we often think in that way in terms of substance use. So one aspect that the crisis of the overdoses, another aspect is hepatitis C. And yet another aspect of the crisis is neonatal abstinence syndrome. And this is also something that is particularly dear to my heart, because of course I don't wish any harm to anybody, but to see the suffering that babies have, I mean, those babies didn't do anything to get into this situation. I think that's very painful, no? And as you can see in the graph, there's been an increase, a fourfold increase in the number of babies with neonatal abstinence syndrome. So that's another aspect of the crisis that is often overlooked, but I wanted to bring to your attention. Another aspect of the crisis in which you as clinicians can also intervene is the overlap with benzodiazepines. So opioids, of course, are potentially lethal, but when you combine them with other substances like alcohol or benzodiazepines, they become even more lethal. And of course, I'm a clinician, so I realize that sometimes we have to combine medications, and sometimes combining benzodiazepines with opioids is not necessarily contraindicated. But we have to be very mindful on when it is indicated, under what circumstances, for which patients, and for which length of time. So, for instance, you can have a patient who has, let's say, a GAD or has a panic disorder, and suddenly they have surgery, they may need an opioid. So in that circumstance, for a short period of time, or they go to the dentist, for a short period of time, they may need opioids. But whether we have to be mindful, again, is for how long they need it. Do you need to lower the dose of the benzodiazepine, or can you, or maybe that patient doesn't really need the benzodiazepine. So another aspect of the crisis is how do we manage medications, not only opioids, but also other medications that may be combined with opioids. Now, one question that often is asked is how did we get here, no? And so there's multiple factors, but at least two of them are the supply side of medications. As you can see, there was a tripling of the opiate prescriptions over the last 10 years or so. And so, of course, if you have more availability, more people are going to abuse them, and also more people are going to divert them and potentially make them available for other people to abuse them. And as you can see from data from a national survey, the national survey conducted by the government called NISDA, you can see that there's two main ways by which medications get into the hands of individuals who eventually abuse them or get addicted to them. So one is when you prescribe them, the individual who gets the prescription can eventually get addicted to the medication. The other part is that individuals may not use those medications and may give them to friends or family, or potentially sell them, and so those individuals can then eventually get addicted. And so one way maybe to think about opioids is the same way we think about antibiotics. So when we prescribe antibiotics, we think about the patient, but we also think about whether that's going to create some resistance and what is going to be the community effect of medication. So we need to think about opioids, not only about the person who is receiving the opioid, but potentially who else could get the opioid. And so we need to educate the patients about only using medications that they use, that they get prescribed, but also not giving medications to family or friends that could result in diversion of medication. The other factor, so the availability has impacted the availability of prescription opiates, but the other side is heroin. And so heroin, the price of heroin has decreased also over the last few years, and it's basic economics that if a product is cheaper, then more people are going to use it. And not only it is very cheap to buy, you can make, if you are a dealer, you can make actually a lot of money trading on heroin, because the cost of manufacturing heroin is about $63,000 per kilogram. You can make about $500,000 per kilogram, so you get the profit of about 10 times. So obviously there's a big incentive to trade in heroin. I'm not recommending that you do it, but I'm just giving you the explanation of how the economics and the underlying forces are leading people to increase the use of heroin. And if you think about fentanyl, I mean, fentanyl is even more profitable. So again, not surprisingly, people are including or mixing or lacing fentanyl with heroin to increase the profit. Now, in terms of what can we do? So obviously, this is a very complex problem. So one person alone or one agency alone is not going to be able to solve the problem. So we need several approaches. One aspect is doing research, which is part of what we do at the National Institute on Drug Abuse and NIH in general. We need better pain management. We need better data. So we need the Centers for Disease Control, the CDC, to collect better data. And then we also have to take care of the overdoses. Specifically, what can you do as clinicians? Well, I think that mainly two things. One is better pain control. So we don't want to deprive people from opiates, because opiates are very useful and often necessary. But we want to keep in mind what are the other ways of providing treatment. And so sometimes NSAIDs or other analgesics or physical therapy may be more effective or better or more indicated, or can be an adjuvant, so that we can decrease the doses of opiates. And so the CDC guidelines have been very, very useful in making a more rational use of opiates. The other thing that you can do is also treat the addiction. And you can act on addiction at three levels. One is at the level of screening. So you probably have different specialties, but if you're primary care clinicians or pediatricians or OBGYN, you can screen and detect the disorders. If you feel comfortable, then you can treat them, but if you don't feel comfortable, then you can certainly refer to colleagues who may feel more comfortable using the medications. And as you know, we have three medications that are very effective to treat opioid use disorder. One is methadone, the second is naltrexone, and then buprenorphine. And buprenorphine, as you know, can be dispensed in office-based practice, so you don't have to go to a methadone treatment program. I wanted to leave you with this slide of the opioid use cascade of care. So what I want to show you there is that there's about 2.5 million people in the US who have opioid use disorder. But of those, only about 60% get ever diagnosed. So we lose 40% already at the diagnostic stage. Then only about 500,000 ever engage into treatment. Of those, you can see in the blue part of the column that very few get evidence-based treatment, and even fewer ever get or stay in treatment for 6 months, which is what we think is the minimum. So if you go from the 2.5 to the people who actually stay in treatment long enough to get appropriate treatment, which is 50,000 people, only 2% of the individuals with the disorder get the treatment that we think they need. I cannot think of any other disorder in which the rates of appropriate treatment are so low. And if we thought about hypertension or diabetes or other, not to think about breast cancer or something like that, where only 2% were getting appropriate treatment, I think there would be an uproar in the whole nation. And so I want to imprint in your mind that there's a long way to go. Fortunately, you are people who can do something to address this issue, and so I want to encourage you to do as much as you can. And so I want to leave you with this. We have a big crisis. The crisis is multidimensional. It affects many people in many different ways. So we have the overdoses, we have hepatitis C, we have HIV, we have neonatal abstinence syndrome, and then we have, of course, all the other consequences. You are clinicians. One of us alone cannot do anything for the crisis, but all of us together can really make a big dent on this crisis. Thank you.
That was great, Dr. Blanco. And I'm going to follow Dr. Blanco. He has given a perspective of the opiate epidemic at the national level. I'm just going to concentrate my talk on Massachusetts State and kind of the efforts we have done there that I think are contributing to addressing the opiate epidemic. I'll introduce myself. I'm Maria Milagros Garcia Quiñones. I am in the UMass Medical School. I'm a professor of medicine. I'm an assistant dean of student affairs and diversity, and I also work for GME as an associate program director of the internal medicine residency program. I do consulting for the public health branch of the medical school and the clinical service pharmacy. And that's where I'm presenting the data that I have today, which entails 15 years of work with the opiate epidemic. And I'm also delighted to be here. So I'll start by talking to you about confronting a crisis and a practical guide for policymakers to be able to address the opiate epidemic. I'm going to talk to you about an initiative. I don't like the phone. I'll talk to you about an initiative we have done at this Medicaid program in Massachusetts where we implemented 3 stages of decreasing the opioids through a prior authorization. And I have no conflicts to report. So this is a picture of Massachusetts, meaning that Massachusetts is among the top 10 states with the highest drug overdose deaths. I can't read from here. Due to opioids. As you can see in the light blue, that's the increasing number of overdose deaths. And as Dr. Blanco also stated, it's similar to the national pattern where you have now the opiate prescription epidemics being the primary contributors to the overdose death early in the epidemic. Then you see in about 2010, 2012, where we then started seeing the heroin causing more contribution to the opiate epidemic. And now in 2013 or so, now you see that it's the synthetic opiates or the fentanyl. And what is more marked about this is the increase in fentanyl and synthetic opiates and correlated with the increase in overdose deaths. Massachusetts is also the lowest opiate prescribing rates in the country. The dark blue color are the number of deaths, as you can see, increasing. And we started working on the prescriptions of opiates in 2005, and that has been decreasing ever since then. But I think the major thing to light is that the most vulnerable population is the Medicaid population with this the opiate epidemic. The Medicaid population has been disproportionately affected. They are 2 times more likely to be prescribed an opiate prescription. They are 6 times more likely to be overdosed, and they are 10 times more likely to suffer addiction, substance abuse compared to the commercial payers. I'm just giving you an example here of data we had in 2005. And what we were looking at is very busy there. But these are the top medications for the Massachusetts Medicaid pharmacy, and what we note is opiates were there. And there were 28% of the beneficiaries were on opioids, and that's 1/4 of the beneficiaries were on opioids. I don't know if you recall back to 2003, 2005, there were no guidelines. There were no CDC guidelines. There were no consensus guidelines. In fact, I will tell you, there was no high dose. You treated, and if the patient got better, then you kept treating, and you would treat until either that happened or you got side effects. Another important thing to know is that there is a balance, especially for this vulnerable population where there's so comorbidities. You do have to treat. There's medical necessity for treatment, but how do you balance that with the negative potential impact of addiction and other consequences in this population? And if you put it into context, you know that that's when all the opiate crisis was happening around us at the national level. So this is a fishbone illustration of all our efforts in putting a prior authorization in the class of opiates. So we started working with the opiates in 2003. In 2005, 2004, I just want to focus on the high dose. What happened is in 2004, we needed to have something to say, hey, this is high dose of opioid. So because we couldn't find it anywhere in the literature or evidence base, we created it. And we created it using our own data. So what we did is we plotted in the x-axis the number of milligrams per day that people were taking, and in the y-axis we had how many members were on those milligrams. What we did get was a bell curve, which is natural, and then we had this huge amount of outliers in doses that physiologically you couldn't even take that showed up in our data. So we excluded those, and we defined high dose as 2 standard deviations above the mean. And that happened to be 360 milligrams of morphine equivalent a day. And we implemented our guideline that if you had 360 milligrams of morphine equivalent a day, then you are defined as high dose, and so we put the prioritization in place. And this was published in the Journal of Managed Care. And back then, what we wanted to show was the literature was saying that states could not control the opiate epidemic with prior authorization policies. There was little signs that they could decrease the utilization of opiates with these policies. We were able to show in a small spectrum from 2003 and 2005 that we did. So this is the data from that study. Look at the average daily dose of morphine equivalents, and we looked at 4 long-acting agents: morphine, methadone, oxycodone ER, and fentanyl. And we saw that 2002 to 2005, we were able to decrease the use of some of these doses in the methadone, morphine, and oxycodone, but not in the fentanyl. So here we are, 15 years later, and we published the second paper. And so this has been published now in the Journal of Pain. And what we are addressing is, were our efforts sustainable? How do we look now? So we wanted to, ever since that first dose of limit in 360 milligrams a day, we implemented 2 more dose limits based on CDC guidelines and the recommendations of consensus guidelines. So we then brought our PA, or authorization, to 240 milligrams a day, and then to 120. And I'm telling you, the new data is they're lowering it down to 90. 90 is supposed to be a high dose for opioids with the new data. So what we did is we looked at the effect of these 3 changes we did, and what we're looking for are 2 things. One is the impact of this high dose limit on the use of opioids, and number 2, or on the use of opiates and on the doses they're using among the Schedule II. So really quickly, the population we looked at, Medicaid, ages 18 to 64, they had to have 1 claim of opioids, and we excluded the dual coverage of Medicare, Medicaid, because they don't follow our PA requirements. This is busy, but what it is you submit a claim or a request for opioids. If you are under the high dose, it pays. If you're over the high dose, we have a work group of a physician, addiction, pain management, clinical pharmacists, that we would do outreach to each of these. And all those complex patients with complex regimens, we work with the prescriber to get this done. This is the data that we gathered. I can't read those numbers, but I remember that the total number of enrollees, I think, is 360, I guess. And then it went up to 385 or something. But if you look at the percentage of those that were on opiates, the opiate users, we managed to decrease it, despite the number of higher enrollments, from 4% to 2% of the population that is in mass health. The other thing we found was women are affected more, consistent with the CDC data, and that the average, the bracket for age is more in the 55 to 64. Which is also consistent to the data of CDC. So these are the results, and these are the important results to take home. If you look at this slide, look at the top. In the This is a slide of the members exceeding high dose. The top graph is doses greater than 120. We were able to bring that down from 40% to 10% of our members are in doses greater than 120, which is a 75% decrease. For doses of 240, we were able to bring that down from 20% to 3%, which is an 80% decrease. And this, remember, this is over 15 years, though. And then for doses of 360, which are our highest dose, we were able to bring down from 10%, because you expect the higher doses to be lower, to 1%, which is an 87% decrease. Now this is, I just mentioned the median and the mean, because remember I told you in the bell curve we had these very high dose outliers, and we excluded from the data. And we just wanted to make sure that they were, that they were affected or dealt with. So if you plot the median and the mean, you will see a big difference at the beginning of the initiative, meaning that the outliers were skewing the data to one side. As we get closer into the bell-shaped curve, we then note that those outliers have dropped their doses. And this, I think, is the message home in terms of the data. This is the average daily dose equivalent used by the top 1% users, top 5%, top 10% of doses. And what is significant there is we don't want to interfere with the doses of opiates in the people that are using it appropriately. We wanted the high users. So we went from 1,200 milligrams of morphine equivalent per day in 2003, now down to 400 milligrams, those top 1 users. We decreased the top 5% users from 500 milligrams, now doses to 200 milligrams. And we decreased the top 10 from doses of 400 to 150 milligrams. So in essence, we were able to sustain our efforts from the beginning. And this is important. We wanted the policy to be very evidence-based. We wanted to develop it in a stepwise fashion because we respect that we didn't want to interfere the treatment plan. We were sequential and progressive reduction strategies, and like I pointed out, the most successful decrease were in those that were using very high opioid therapy. And they were, that we probably wanted to address. So I think that what we were able to do is bring up an option for the Medicaid and other payers and programs to think about how they can manage, at some way, these opioids. Limitations, I'll be really quick. We used one subgroup, Medicaid. But Medicaid in Massachusetts is 1.86 million members, so we had a good sample. Number 2, we only used Schedule II opioids. We didn't use combinations, but we acknowledged that combinations are the most used. And it was because we couldn't attribute the Tylenol dosing. That was a challenge. Number 3, we recognized that the national efforts contributed to our work, and so it was part of it. Number 4, that probably the doses we put out are low because people are paying cash, and we weren't able to capture that. So I want to finish with this email from Hawaii, which I was very excited about because finally somebody's reading our paper in Hawaii, right? So it was quite exciting, and it says, "Aloha, Dr. Garcia. I came across a reference to your recent article in the Clinic Plan Advisor newsletter. Honestly, I got very upset. Not because I felt the premise, assumptions, or conclusions were incorrect, but because of the unintended consequence this type of thinking has created. I often feel that people doing research have very little idea of what is actually happening in the real world, and physicians who are working in the communities." 3 pages later, it says, "I'm sure you and your team had the best of intentions, but I really think it's really important that you also consider the unintended consequences, creating more barriers to care and administration roadblocks." So my answer to that, I think he's right. It is important. However, this is what I would answer. There needs to be a balanced approach. So it is a collective interest as healthcare providers to ensure that the patients are appropriately treated for pain. However, all prescribers and payers definitely need to balance the factor of monitoring continued medical necessity, risk of abuse, and the potential of addiction, which is real. Thank you. So I am going to present our third speaker, Dr. Arthur Jeske. Dr. Arthur Jeske earned his PhD degree in pharmacology and the DMD degree in the Medical College of Georgia. He's the editor of Contemporary Dental Pharmacology, Evidence-Based Considerations, editor-in-chief of Moby's Dental Drug Reference, and the section editor of the Journal of Craniomandibular Sleep Practice. He has served in the American Dental Association's Council, Scientific Affairs, and is also in the International College of Dentists, American College of Dentists, Academy of Dentistry International. He's the recipient of the Distinguished Alumnus Award from the Medical College of Georgia School of Dentistry, and he's a professor in the Department of General Practice, Dental Public Health, and Associate Dean of the Strategic Planning and Continuity Dental Education at the University of Texas in Houston.
Thank you very much, Maria, and I want to thank the Hispanic Medical and Dental Associations for the honor of being here, privilege of serving on this panel. I also want to give a special thanks to Dr. Anna Meunier, who connected your program committee with me. Again, it's a great honor. So let me go ahead and launch into this, and I have a rhetorical question for you at the beginning. And the question is this: why is it both impossible and undesirable to completely eliminate opioid analgesics from the management of pain? And the answer lies in this structure. This is the crystal structure of the mu opioid receptor. We are programmed to respond to opioids through a huge number of receptors that are endogenous in virtually all species and ubiquitously distributed throughout the neuraxis. They create a number of positive effects when administered to us, as well as a number of negative. And the point that I'm going to drive home today is that in the trenches, there are opportunities for us to minimize, but not eliminate, the use of opioids. So I want to start off with a brief description of the dental pain model, which frankly is the industry-wide, pharmaceutically accepted model to study single-dose oral analgesics for the management of acute pain. Okay, so the patients are typically well-suited to this because they're young, they're ASA1, they have very few complicating conditions, and because this surgery traumatizes both soft and hard tissue. So we get feedback through the trigeminal nerve from multiple types of nociceptive nerves. So it also, fortunately or perhaps unfortunately for some people in studies, it has a very low placebo response rate of about 15%. So about 15 out of 100 subjects who receive the analgesic will get relief from just a placebo. It also reliably goes to severe pain for a short period of time. Now, we can't do these studies any longer in the United States, but this is based on research done in the mid-1960s in San Antonio, Texas, at Wolford Hall in United States Air Force. And they recruited 100 volunteers, 50 males, 50 females, to undergo third molar impaction surgery without the benefit of any analgesic therapy following the procedures. And of course, you can't do these studies anymore, but they needed this information to design good pain control protocols. And so you can see that at about 6 hours, the pain touches 7 and just exceeds it, which is severe pain. That's a visual analog scale, 0 to 10. And then by 24 hours, the pain is abated quite a bit, although there's a small rebound effect, probably caused by late synthesized mediators and the introduction of tissue fluid in the form of swelling. And you can see that by the third postoperative day, all is pretty much well in terms of pain level. Now, there are two comorbidities that go with the removal of third molars, and if you've had your wisdom teeth extracted, you probably know what these are. One is trismus. You have limited opening of your mouth caused by inflammation of muscles, irritation of motor nerves, and then you have swelling. Notice, though, that these two comorbidities, while they overlap the pain, are also abated by the third postoperative day. So the strategies that I'm going to present to you today for minimizing the use of opioids at point of care are based on this particular model. Now, you're all probably familiar with the term NNT, but I'll just briefly refresh your memory. NNT is the number of subjects, it's a statistical term, the number of subjects who must receive a therapeutic intervention in order to see the defined therapeutic benefit or the effect. So in terms of pain research, when you get an analgesic that produces this effect, 50% or more reduction in pain in about 70% of the subjects, you get an NNT that is extremely low, meaning it's a very good analgesic. And I will show you some NNTs. So keep the number 2 in mind when I present some of these data, and look at some of the comparisons that we have for the various analgesics. Now, this was an exciting development in terms of scientific literature because it comes from the Cochrane Library of Systematic Reviews, and it is published by world leaders in pain research, the group at Oxford, other individuals in the UK who routinely publish systematic reviews of randomized controlled trials comparing a single dose of an analgesic in typically the third molar model against placebo. And while the third molar model is the most widely used model, of course there are medical models as well, hemorrhoidectomies, bunionectomies, laparotomy incisions, and so forth. But the third molar model is much more controllable and very, very predictable. So the title of this article was Single Dose Oral Analgesics for Acute Postoperative Pain in Adults, an overview of Cochrane Reviews. Now, folks, you have to understand, I'm sure you do, that a systematic review is the highest form of scientific evidence, right? That's level 1 scientific evidence. Well, when you get these experts reviewing multiple systematic reviews, you get very, very robust guidance on pain control. And so we'll take a look at this. These are some of the NNTs that were reported by Moore and others in this particular publication, as well as in previous single systematic reviews that they did. And I call attention to the one at the very top, ibuprofen 200 milligrams plus acetaminophen 500 milligrams, 1.6. Folks, it doesn't get much better than that in pain control. Doesn't get much better. I also call your attention to the extended duration that you get when you increase the dose of ibuprofen and acetaminophen, or you use a higher dose of acetaminophen with oxycodone at a higher dose. And then finally, and this may be somewhat surprising to you, look at the bottom. No systematic reviews of hydrocodone, the principal opioid in Vicodin. You say, why? Why is that? We use it all the time, right, in the United States. Well, the answer is worldwide, it's not very much used. It's banned in a lot of countries. And you know, it recently became, well, not so recently, but it became a Schedule II controlled substance. So I'm going to present data based on these scientific discoveries. And I also want to give you some idea of the timeline for dental types of surgeries that may require extending beyond the 3-day period for pain control. So this is from periodontal graft surgery, and it shows that for thinner grafts, this is graft thickness, thinner grafts, the pain really doesn't, it just barely goes to moderate levels at day 1, and then tapers off by day 3, and by day 7, it's very much like the third molar model. But for thicker grafts, you can see that it goes to severe, right, for a very short period of time, day 1, and then it declines progressively, but even by day 7, it is still perhaps requiring what we used to call prescription analgesia. And I'm going to introduce a new term for you today, call it provider-directed analgesia, because if we're going to use over-the-counter drugs realistically, it's something we have to direct and orchestrate. All of these differences, by the way, were statistically significant at all points. So we come to this model for tooth extraction, and this could apply to outpatient medical procedures as well. Tooth extraction, the horizon is probably 1 to 3 days for the more intense therapy. For endodontic therapy, it can be prolonged, and the dentists in the audience know that when we traumatize the periapical bone, then we tend to have longer duration of postoperative pain, and periodontal graft surgery 7+ days. So when I hear about recommended limited durations of pain control, I think that certainly 3 days is definitely realistic, but certainly it needs to be at least 7 days, and perhaps in some cases beyond, again, based on the type of surgery that you're doing. So the endodontic model is very much like the oral surgery model. So provided directed analgesia. All right, so I ask you to consider ibuprofen 400 milligrams, 1 tablet. Here's the minimal effective dose level, plasma, and here's the peak. See, the peak occurs at about an hour, and there's the sweet spot. The shaded area is the area under the curve above the minimal effective concentration. That's where we want to live, and the best way to get there and stay there is to administer the drugs at the appropriate dose and to subjects who are not eating, who have not eaten a large meal. Virtually all of the studies that are the basis for this recommendation come from subjects who were fasting, and that of course produces a pharmacokinetically comparable model for all of the subjects, okay? So it goes down, and then of course after about 5 or 6 hours it's redosed. Now, you might want to pay attention to the new dose forms that are available commercially. It's no accident that gel tabs, gel caps, and liquid preparations are becoming more popular. And why is that? Well, because they're 100% bioavailable. They're guaranteed to dissolve, whereas compressed tablets may not undergo quick degradation in the GI tract and may not be as well absorbed. So one of the strategies that you can employ is to recommend a liquid preparation. I've even recommended children's Advil to adults. Now you have to give it to them in an adult quantity, but it's certainly something that you might want to consider for short term. All right, now let me turn my attention to the opioids. Consistently variable. And from subject to subject, there is a great deal of variation. We can have dysphoria, euphoria. We can have no analgesia. We can have excessive effects of the opioid. And those are based perhaps on polymorphisms of the cytochrome P450 system, specifically CYP2D6. You may recognize that isoform. And there are many, many different effects, some of which are very good. Of course, cough suppression is very good in many models. Certainly respiratory depression is rarely a beneficial effect, but the sedation that you create may actually be beneficial in the postoperative period if you want to limit the movement of the patient and provide a sleep environment, better sleep for the patient. So you can take advantage of these. Of course, you don't eliminate allergy with this regimen, but you get away from, when you use an opioid and acetaminophen, you get away from some of the adverse gastrointestinal effects and the adverse effects on platelets that you get with the non-steroidal anti-inflammatory drugs. So let's turn our attention here. Now consider this graph for oxycodone. This is from the manufacturer, and these are 3 different doses of oxycodone: 5 milligrams, 15 milligrams, and 30 milligrams. Here's the minimal effective concentration for a single dose in a naive patient. Here's the minimal toxic blood level, okay? There's therapeutic, there's toxic, and there's my sweet spot between 5 milligrams and 15. Now, I'm going to make a case that when you use oxycodone for a short term, you use an effective dose. That is one that will exceed the minimal effective concentration, and that would be 10 milligrams. Notice that the manufacturer's data, the manufacturer recommends 5 to 15 milligrams every 4 to 6 hours. But remember, when we combine this with 1,000 milligrams of acetaminophen, we get 8-hour duration, 8-hour duration. So if you're concerned about acetaminophen, then how many doses are you going to give in a 24-hour period? 3. You're going to give it every 8 hours. Remember the data that we showed you earlier. So that's 3,000 milligrams. That's within limits. You may be using a 4,000 milligram limit. You may be using a 3,000 milligram limit, but you are at a reasonable dose for a very short period of time. Please keep in mind the pharmacogenetic variations that we encounter in these patients. Codeine being metabolized to its active form morphine, and hydrocodone being metabolized to hydromorphone, okay? And there's a lot of variation that comes about as a result of pharmacogenetic differences. I wish that all of our patients would walk in with their pharmacogenetic profiles. Maybe 23andMe or Ancestry.com is going to catch on to that, and it'll provide us some data that we can use. Wouldn't it be nice? Because in the past, when I prescribed Vicodin to somebody, they come back and say, well, I didn't get any pain relief. Well, I immediately assumed, what? That they were druggies and they were after some more drug, when in fact they may not have been able to activate the drug. And then let me just briefly go back. Of course, now codeine has a black box warning on it because of the disasters that have occurred in children who had ultra-rapid metabolic capabilities for cytochrome P450 2D6. And so oxycodone has many favorable characteristics compared to hydrocodone. And oxycodone is a CYP3A4 substrate, so it doesn't suffer from the CYP2D6 polymorphisms. So, at the end of the day, this is what I do following tooth extraction. You physicians may want to do this following routine outpatient surgical procedures. And I write this on a card or print it out. For pain relief, take 400 milligrams ibuprofen, and I say 2 Advil or whatever you got, with 1,000 milligrams acetaminophen, 2 extra strength Tylenols immediately within 1 Q8H. And I point to the with. I highlight it, I circle it, because what do you think they say? Oh, you mean you want me to take the ibuprofen, then 8 hours later take the acetaminophen? No, that's not how it works, the scientific evidence. And by the way, you can call up the systematic review, your chair side, you got a computer, show them the NNTs, tell them what an NNT is. Now, if you can't use that, and an opioid is the drug of choice, then oxycodone immediate release 5 milligram tabs dispense 6. Take 2 with 1,000 milligrams acetaminophen immediately, then every 8 hours, and then of course all of the usual warnings. Now what do you think the pharmacists say? They call me back and say, doctor, didn't you mean OxyContin? Or doctor, didn't you mean 16? Or didn't you mean 26 or 36? No. I'm going to treat the most severe outcome. Remember, the window of opportunity to manage acute postoperative pain occurs mainly in the first day, unless you have complicating factors. So you want to come out of the gate strong. So if you're thinking about dose escalation over several days, you're missing the boat. Okay, so a couple of other things I'll leave you with. Preemptive analgesia. What about the NMDA receptor, the N-methyl D-aspartate in the dorsal horn of the spinal cord that causes sensitization of the central nervous system? We know that dextromethorphan is a NMDA receptor antagonist. Cough medicine seems to enhance preemptive analgesia, and there are good studies about it. Here's an example of a great study, and the outcomes suggested that 90 milligrams of dextromethorphan administered 90 minutes before the procedure reduces opioid requirement by about 50% in the postoperative period. So, corticosteroids, don't forget about those as potential preemptive agents to use prior to surgery. And then don't forget about guidelines from professional organizations. This happens to be the guidance from the American Association of Oral and Maxillofacial Surgeons. all very salient, very important points. You can go to their website and download these, very, very important. And don't forget about prescription monitoring programs. They are a wealth of important information. So with that, I'm going to close. Thank you, and muchas gracias.
And I think now, thank you very much. That was great. We're open for questions.
Is Heroin. I'm a family medicine doctor in Madison, Wisconsin, and this was actually very helpful because I think we get a lot of patients that actually call our clinics after they have procedures, and we need to have a guideline on what to do. And my question is around that because I also treat a lot of patients that have tooth pain because they have an abscess, dental abscess, or periodontitis, or different other reasons. Will this help with that kind of pain too, like the combination of the ibuprofen and the Tylenol?
Yes, they will help that kind of pain. One thing you need to keep in mind, though, is that pulpitis, which is extreme pain caused by stimulation of a tooth, is not amenable to antibiotic therapy. Okay, so when you have patients who call in requesting analgesics, they also typically ask for an antibiotic. Unless there's apical inflammation and infection, the antibiotic is not going to do them good. But clearly, you can use this regimen to help reduce the pain preoperatively. But remember, the evidence that I've cited is based on single doses, and it doesn't inform us that well about the adverse effects of continuing this, although clearly they are minimal because they've studied the effects and they turn out to be actually about the same or even less than placebo in most of the studies. So yes, it is a good strategy, but it should only be used short term before getting the patient treated.
Thank you.
Edwin del Valle from Puerto Rico, very scholarly presentation. I just want to share, in addition to what you said about treating acute pain, with the physicians in the audience, especially those in emergency room settings, the best way to treat acute dental pain is with a local anesthetic injection, okay? Many patients seeking care or attention for acute dental pain are actually overdosed in emergency room facilities, and their pain won't go away. So if you have a dentist on staff that actually does emergency room duty, contact that person, or as I have been trying to teach some emergency room physicians on how to administer local anesthesia in the oral cavity to help take care of the acute situation until the patient is referred to a dental office.
Wow, am I glad to hear you say that. I teach local anesthesia at our dental school. And the anesthetic I would recommend that you have is articaine, septicaine, and it can be administered simply by buccal infiltration in the mucobuccal fold. Use a full cartridge. And then to follow up on your initial comment, the best treatment would be, if you've got an oral surgeon on staff, after you've done the local anesthesia, take the tooth out.
I also want to comment on the fact that certain populations are very at risk. I mean, even children going for dental procedures and coming out with an opiate is something that is very concerning. So it's just the wise use of it.
Excellent set of talks. Thank you for that. And particularly the trends slides were really good and informative for me. My name is Gene Santana. I am a PGY2 and anesthesia resident. And my question is to the panel, has there been an increase in referral to interventional type procedures in patients, not necessarily in the acute phase, but also in the chronic phase of pain management with the downtrend or decrease in opioid prescription?
It's nice seeing you, James. Yes. I think what happened in the past is we relied on these medications because they were presented as safe and certainly as very effective. And I think the anesthesia contribution for the management of these pain were addressed with taking a pill. And I think as we are now changing our gears, the procedures are very helpful. It's not as, we don't use it as much as we probably should. Probably we need to do better in identifying who would benefit best from that intervention. But there are many hospitals, I guess, I don't know if there's a raised hand, that has these anesthesiologists doing procedures for pain management. There's some, yeah. There's some that don't, and in our hospital we used to. We don't now. So I think that's a limitation, and I think that anesthesiologists in the past were experts in pain management especially, and would go to that field. But I think as more procedures are now an option, because the guidelines mandate that you consider procedure intervention for pain management, I think you're going to have a nice job. It's going to be good.
Thank you very much.
Hello, I'm Dr. Williams, and I'm a member of not only the National Hispanic Medical Association, but I'm on the board for the Association of American Indian Physicians. And it's been a long year and a half for me personally in the state of California. And I know you guys are talking research and you're not talking politics, but this group really has to know what's been going on at the medical board level, not only in California, but in other states. And I need to mention this because it's really putting doctors at risk. I think your study from Massachusetts really can help a number of these doctors. But the issue is primary care physicians are the doctors of last resort. So if we do not treat the patient's pain, they go to the street. They go to their friends or their family members to get pain medicines. And this is the unintentional cause of what's been going on with CDC recommendations that have been enacted since about, I believe, 2013, 2014. What the CDC and what the medical board did in the state is they took those recommendations and they held all the doctors in our state to these standards. And then they filed allegations against the doctors' licenses who are not following through with the CDC recommendations. So now we normally get about, say, 800 doctors investigated with allegations a year. Now it's almost 10,000 doctors in the state. And that is costing each physician over $100,000 to protect their license. Kamala Harris, what she did in our state is there's also something called the Death Certificate Project. And any patient that dies with opioids in their bloodstream, the doctor is automatically investigated. So what has happened in California? Can anybody predict? Nobody's getting their pain meds. They're not getting them from the ER. They're not getting it in primary care. We only have pain doctors, are about 5% of all doctors. Not even the pain doctors are prescribing. So, and those who continue to prescribe are unfortunately at risk with their license. And I know this because I'm one of these doctors. And as a result, it's nearly broke my family financially. So I appreciate the research, but these are the unintentional causes of all this. Now, we also have issues with managed care in California, where, And unfortunately, some of my patients were under Cinermed, and they weren't approved procedures. They didn't get their referrals. They just ignored them, said they didn't get them. And now they've actually lost their ability to take care of Medicaid patients. And there's other groups that are in trouble too. So patients can't get their drugs, and they can't get their procedures. So right now, another thing I need to bring, these issues that with the opioids have affected doctors so much that and managed care and meaningful use and all these things that doctors have been going through. We have the highest rate of suicide of doctors at any time in this nation. And I don't know if you all know this, okay? So it is a serious matter. It's doctors' careers, it's patients' health. And I know we want to be all bright and cheery about medicine for the students that are here and the residents, but these are the issues where politics impact medicine. And we as a group have to be able to stand up to this to make sure that our patients' voices are heard. But I wanted to make sure that this is addressed because it's very important for our future.
Thank you very much. I think that, and I don't know if you want to talk about the CDC, but I'll tell you that it brings a kind of the dilemma that we face when we're doing the right thing and when we're managing pain. And now we have better tools because at least we could manage the people who do not necessarily have a problem. There are many, many ways that now we have Suboxone, we have other therapies that if those are the issues we can give, whereas in the past we didn't. I do recognize apparently, because I was reading yesterday or the day before, that the CDC came out and said that they didn't mean what they kind of said in certain restrictions. Thank you for letting us know because I didn't know where that was coming from. They wanted to make it very clear that patients with cancer and end of life and other serious illnesses or like sickle cell that require pain medications. You can't take those away. So I think, and you're absolutely right, there has to be a balance between us understanding the need for treat, but on the other hand, managing the other side, not eliminating it, not decreasing it, just appropriately treating it. But that's where it happens. I mean, I'm surprised to hear that they took such an action to physicians because that's, especially in Massachusetts, that's tough to do. You need to have a lot of evidence for that. But I'm very pleased you brought that up. Yeah, you can't do that. Yeah, I don't understand how that. Yeah. 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 Yeah, and yes, that's a great point. Sometimes you need higher doses to when you're treating for pain. And the fact that you brought up is the illicit drug. And that has occurred when that was the balance we were dealing with in Massachusetts. And there's still a question, and I don't know, nobody's brought up that point, but certainly the question that when you control one thing, they're going to go into other, which is what you stated. We're very aware of that, and that's why we have to be conscious about that. Thank you. Yeah. Yeah. Yeah, we've covered Suboxone since it came out, just because we understand the importance of it. Okay.
I wanted to ask you one question. I was very impressed by your study, and I wanted to ask, following up with this idea of balancing the addiction versus treatment of pain, how much pushback did you get from patients who were on higher doses and you were trying to reduce? And then, do you have any suggestions on how to handle that and how to address, how to discuss with patients and families which may have very, very legitimate concerns about undertreatment?
Yeah, I mean, I think, and again, these questions, we in Massachusetts, what we did is we used this work group, and we try to work with the prescriber, We never, as you see, and I didn't go into details, but when they submit for a claim, what we do is we ask information. We ask, what's your plan? Not our plan, what's your plan? How do you think you need to do that? And we reach out. We do peer-to-peer reach out all the time. There's some physicians that either, want to keep doing what they're doing. They feel that the patient would do terrible if you don't, if you make changes. We work with them. So we say, how much do you need? 3 months to try it? And if, in those that were very high, I'll tell you just one example. We had people who were, have you guys heard of compounding opioids into powders? Yeah. We found that in Massachusetts, people were compounding opiates into powder to do that you couldn't take physiologically through your mouth. And so what we did in those, we put FDA guidance. There's no FDA approval for that. We can't cover it. So what you do is you balance what you can do and the appropriateness approach. And I think if you reach out to prescribers and work together, there'll be some that don't want to do it, and then there's an appeal process. They have the right to appeal. And they'll be covered with the medication until that resolves. But those are very good points.
How about you, Arthur? How do you, if patients, raise the concern that they're going to get under-treated with the treatments that you recommend, how would you advise us to address the patient's concerns?
Yes, we do always have a subset of patients who say that they need an opioid or they want an opioid because they've had it in the past. This is very important because indeed, based on polymorphisms, genetically determined drug metabolism variations, they may not get good relief, or they may get excessive effects from normal dosages. We deal with that by trying to improve the dose of the over-the-counter medications. We always emphasize that single-dose therapy for acute pain is not, single drug therapy is almost never appropriate when we have the option of adding ibuprofen and acetaminophen. That's our response to it.
Great. Luigi.
Thank you so much. Pierluigi Mancini. Wonderful presentation. I wanted to circle back to the treatment part and having Hispanic providers in the room and you guys. Wanted to see if you had any information in your particular areas about how many Latino physicians are participating in medication-assisted treatment, in buprenorphine, because it's part of what I think we're missing, and I wonder how many are aware of billions of dollars are going to every state in the United States to serve our population, and what are we doing? How are we participating in that?
So I don't have the data with me. SAMHSA collects the data on the individuals who have the buprenorphine waiver. So it should not be too difficult to get a sense of that. But you're probably right that, in general, underserved minorities tend to get less access to treatment, and that's compounded also by socioeconomic conditions. And so it makes a lot of sense what you're suggesting about trying to identify not only how many, but also the distribution, because if you have, let's say you have 100 physicians, but all of them are in Washington, D.C., or in Boston, or in New York, that's not going to address the needs of the nation. So to look at the distribution and potentially look for some solutions like telehealth or other ways to, use like hub and spoke models to expand the reach. So I think that's a very, very good suggestion, and thanks for bringing it up.
I'll ask the audience, how many of your institutions mandate MAT to be certified as physicians to treat with buprenorphine? Okay, 2, 3.
So you better tell them they have to go to that special training to get the
Yeah, they make it much easier now. So you just go into the computer and you're trained. We're doing that mandatory in our institution and in the ED. So the ED is expected to send patients when they are seen there. So the Hispanic is interesting, but it's really going to be one of those mandated policies. So I think. Oh, hi.
Maria Puy, Chula Vista, California Latino Medical Association. there really aren't that many programs to treat drug addiction and addiction in general. I would think it would be the federal government that should start looking at models and then do testing. Because at least in California, we have fallen prey to a lot of organizations who give drug addiction therapy, which is basically nothing, and charge a fortune for it.
Yeah.
So this is for the federal government.
Yeah, I mean, I think...
Please get models.
Yeah, I mean, in Massachusetts, we had the opioid epidemic, and the state responded very differently, and one of the mandates was to increase the accessibility to opiate treatment addiction. It's money.
Oh, yeah.
I think. I don't know what others think, but I think it's resources and money, so it's difficult, I think. I don't know from the national...
So SAMHSA, as you know, got about $1 billion 2 years ago to expand treatment, and so what we did from NIH, from the National Institute of Health, is we awarded grants, and we are studying how different states are responding and see what responses are more effective. However, that's not going to be enough, and I think as citizens, what we could do is also advocate for more resources, as Maria is saying, and also advocate that that treatments that are not evidence-based do not get reimbursed. Part of what happens is that a lot of money goes to treatments that are not evidence-based, and those resources are sort of detracted or taken away from medication for opioid use disorder. So we need science, but we also need advocacy to reallocate resources.
It was interesting that because the Affordable Care Act made it mandatory to have mental health
Yes.
services, a lot of snake oil merchants came out of the woodwork, and that needs to be very carefully monitored.
Absolutely. I think we ran out of time. Thank you for your attention. I just want to make sure that you go to the next workshop on page 18 of your program, and that make sure that you join tonight in the Independence Bee for the exhibit hall. Thank you.